Hi, my name is Dr. John Dymar. I work at the Norton Leatherman Spine Center. I'm part of Norton Healthcare Bone Optimization Task Force, which consists of myself, Dr. Robin Curry, and Dr. Jan Teeter, along with other healthcare professionals. We have quite a few growing core of nurse practitioners that help treat osteoporosis, both for our practices and for the system itself. And we're recording a series of lectures to tell you how to diagnose and treat osteoporosis. And we're going to also show you some case histories. And this is really should be the opening introduction lecture because we want to talk about understanding bone physiology and why it's so important. We consider this to be one of the main systems of the human body. I know we have cardiovascular and endocrinology and gastrointestinal, and we all, as physicians, think that that's the most important system of the human body. But the skeleton, I would like to reiterate, is important because it allows us to walk, it gives us support, it serves as bone marrow deposition, it also serves for the reservoir for all the calcium in the body. And so it's relatively important, and that's why it's very worthwhile with your patients to consider evaluating their bone health by doing DEXA scans when you age, by maintaining good vitamin, particularly vitamin D intake, and understanding basic bone physiology and how we get into trouble. Virtually every major system disease, such as liver disease or kidney disease, and we'll come back to that, will actually affect the skeleton, and in a lot of ways extremely detrimentally, that you can suffer pathological fractures and a lot of things that may seriously hamper a person's ability to walk and have a normal lifestyle. And many of these things, the most common ones certainly, can actually be mitigated by identifying bone metabolism problems that are going awry early. And so that's why I'm going to talk to you a little bit detail, and hopefully I'll try to put it in a logical thought pattern of why it's important to pay attention to vitamin D and pay attention to calcium, and also common things like diet and obesity and exercise. These are all things that maintain the skeleton. So the learning objectives are basically somewhat clear-cut. The participant will understand the essential aspects of the physiology of bone. The learner will understand the effect of renal and liver disease on vitamin D3 and what affects that. For example, dilantin affects the P450 system in the liver, and it will result in vitamin D2 not being metabolized in the liver and produced and put into the circulation to go to the kidney. And this can result in osteoporosis and osteomalacia. So very simple things like that can block the function of a critical vitamin that we'll talk about. The participant will appreciate the laboratory testing required, which is relatively simple for osteoporosis diagnosis. And you will be amazed that when you do this algorithm, how many other ancillary illnesses you will pick up that will need treatment and further laboratory testing beyond just the basic testing for osteoporosis. The learner will also appreciate the critical system-wide hormonal effects of vitamin D3. D3 functions not just so much as a vitamin necessary for bone metabolism, it does many, many other things that are critical in the body, and it's a very primitive hormone that's probably been with us for many millennia. So it's very widespread as far as the systemic effect of it. So when you look at the composition of bone, bone is flexible. It's what we call a viscoelastic material. When you take a step, it actually bends a little bit. Just like an airplane wing, it is made out of composite material. And out of that complex, about 40% is organic matrix, or what we call osteoid, which is collagen, and various other proteins that are embedded within it that give it its structural stability. 60% of it is mineral, and that's where we actually deposit various types of calcium compounds into the bone to stiffen it and make it more durable. So you could remove all of the calcium from a bone and you would still have a bone there. It would just be extremely flexible, just like a collagen, for example, a meniscus in the knee or something along that line. And so these two substances make up the core components of bone. Now, when you look at the organic matrix, about 90% of that is collagen type 1, we call it. And that's the building block of almost all the things in your body. There are 10 different types of collagen, all doing different kinds of activities and structural support within the various joints and ligaments and bone in the body, and also a lot of the soft tissues. So it's type 1 collagen, which is important because that's the basic defect that we see genetically and is familial, that it may not be quite right, that results in osteoporosis in a lot of people as they age. The other 10% is ground substance, and within that are the glycoaminoglycans and the glycoproteins. The most famous one, of course, is bone morphogenic protein. There's 12 to 14 of those known, and they work in sequence to build collagen and to build the bone and to reossify the skeleton. And those have been isolated and are now used for the last 2 decades in bone fusions, because we can use BMP2 and put it on a sponge and put it into a fusion, for example, or a fracture, and it will actually stimulate the formation of the fusion or bone healing. And that's been a real breakthrough, the biologic treatment, as with many other illnesses, in getting bones and fractures to heal and fusions to heal successfully. Now, within the mineral component, you have calcium and phosphate, calcium carbonate, sodium, magnesium, and fluoride. You remember how in the old days we used to give fluoride to patients to stiffen their bone, and it was an early osteoporotic treatment? Well, it's deposited in the bone, and it makes it harder, but also makes it stiffer and more brittle. And so that's kind of, because of the side effects, also has fallen out of favor with our more contemporary bone treatments that we have, such as the bisphosphonates, starting 20 years ago. So that's the basic composition of bone, and you can come back to this diagram to review it if you'd like as we go through it. Now, the basics of bone formation. Bone, of course, in utero forms either by enchondral ossification, a cartilage analog, for example, a bone, or the joint itself, the head of the femur, for example. We also have what's called intermembranous ossification, where you form cartilaginous cells directly within soft tissue, and that also will cause ossification. For example, I believe the tables of the skull are formed that way. So bone is continuously remodeled through life, and I'll probably come back to this through the other lectures that we've already recorded that you're welcome to look at about diagnosis and treatment. But your skeleton will replace itself every decade, which is pretty remarkable. The reason it does that, if you're not constantly remodeling the bone, you will exceed the ability of it to support yourself, and you'll get fractures. And the most common example of these are stress fractures. I just saw somebody I talked to who went from 20 miles running to 50 miles running, and sure enough, she exceeded the ability of the bone to remodel and heal itself, which is necessary because we have little microfractures probably occur with everyday activity, and she exceeded her ability to heal that and develop a stress fracture, and that's kind of a major deal in the femur, because particularly the femoral neck, because you have to basically go on crutches for 3 or 4 months to hopefully allow that to heal. So we're constantly remodeling our bone, and it's a disruption of that normal remodeling and making more bone to remodeling and taking away bone that gets out of whack as we get osteoporosis as we get older. In other words, we don't form as much bone as we lose, and that's what leads to osteoporosis as we get older. Any imbalance in both the genetic and metabolic homeostasis results in some sort of bone disease, whether that's a tumor releasing factors that will erode the bone, or it's having a parathyroid adenoma that produces too much PTH that causes mobilization of calcium out of the bone and dumping it through the kidneys, and also loss of phosphate. They're in a very close relationship. I'm not a nephrologist, so I don't know the precise things along it, but just say that you do lose calcium, that will result in softer bone, which makes certain sense. Kidney disease is a good example of how you can develop a lot of problems, and even problems with dialysis, such as what we call renal osteodystrophy. The integrity and function of the bone are maintained by this precise equilibrium between the cells within the bone. And it's very simple. We have what's called osteoblasts that will make an osteocyte that make bone, and we have what we call osteoclasts that resorb bone. So this is how we get the remodeling. We make bone, we resorb bone. And that is a very precise relationship, and those cells talk to each other within the bone and regulate that bone formation. So osteoblasts are responsible for the formation of bone. Osteoclasts are bone resorbing cells. They're both essential for remodeling. In addition to that, there's many hormones such as PTH and calcitonin and even vitamin D, and there's that control basically the rate of reabsorption and remodeling and bone building. And there's also various proteins that are not only critical to all tissue health and reproduction and remodeling, but it's basically TGF-beta, the BMPs that we've just talked about, and parathyroid hormone are critical for the bone physiology. So that's a brief review of the basics of bone formation. Now we're going to talk about the formation of collagen. And there are so many diseases that you're going to encounter, skeletal diseases, most notably Marfan's and Ehlers-Danlos syndrome, that are all defects in collagen formation. But the most important one you're going to encounter is COL1A gene, and COL, collagen, A1-2 gene, those somehow are genetically predisposed people to developing osteoporosis. And it's believed to be a genetic trait that as people get to be older, something happens that if they have the defective collagen 1A1 gene, they develop osteoporosis. So there is a genetic familial basis for this. For example, Northern European white females, because of the fact they carry this collagen gene, they are predisposed to developing osteoporosis more than somebody else. We also see it in Afro-Americans. We rarely see osteoporosis, particularly on the continent of Africa, because there the bone is much stronger and they're less likely to have osteoporotic fractures such as a hip fracture. Now keep in mind, in the United States, that being the great mixing of society, you may still see that in Afro-Americans because there are a lot of gene issues where over time they've been mixed up, and so you may have it occur in any population in the United States, including Asians. And so pay attention, they can occur in any population. The alterations of this gene cause a lot of problems. They cause osteoporosis that we just talked about, Ehlers-Danlos syndrome, Marfan syndrome, osteogenesis imperfecta, which is basically these children have soft bone and they have multiple fractures, and almost everybody will have one of these in your practice. It's not an uncommon disease, and a lot of other diseases that we don't need to go over here. So really how it all starts is you have the collagen that will make basically messenger RNA within the nucleus, just like we make all the other proteins in the body. There's nothing different. We're just talking about a specific protein here. In this case, a messenger RNA that's going to code for collagen. The majority of defects in these genes are responsible for a lot of our metabolic bone diseases that we just talked about. Now, you take these, and basically these are taken into the endoplasmic reticulum that makes our proteins, right? And the protein synthesis translates, produces ribosomes. The ribosome is the actual encoder that takes the messenger RNA, and on the other side it'll actually code out the protein, almost like a production line. And the protein synthesis via the translation, you use it'll make two chains of colla A1 and one chain of A2. And the reason why that is, this is the famous triple helix that winds itself together, that makes all the collagen, that makes our bone and all the ligaments and joints and articular surfaces in our body. Comes from this one triple helix. It's not a double helix, it's a triple helix. So it puts it together like this and winds it up. There's our three chains. And then the ribosome winds, after it makes the protein, it takes one of the proteins within there, will take it and wind it up into the triple helix. It just comes together. And during the folding, specific proteins modify and regulate the process. And some of them are listed here in the little boxes there. It's not important you remember those. It's just remember that virtually every one of those has been found in the human genome across the world to be defective. And every one of those people will develop some sort of bone disease. Osteogenesis imperfecta. There's like 21 different types of that. And we always thought it was just 4. So when we have a defect in one of these proteins, like basically the LAPR11, you will likely develop some sort of soft bone type or metabolic bone disease. So you make your triple helix here. So it goes down here and it winds it up. You've got a nice triple helix. This is the raw form. It goes out of the endoplasmic reticulum into the cytoplasm and comes in here, as you see here, and then it's called procollagen, various enzymes lop off the edge of it. And one of them actually is BMP1. So BMP1 is actually, it makes bone, and it's important for bone, but what it does is it trims down the collagen from the procollagen down to a regular triple helix and makes it into something that will be suitable to manufacture bone and other tissues within the body, and that's collagen type 1. So that's put out of the extracellular matrix, and it winds up spontaneously and cross-links, as you see here, and forms fibrils. These are just like threads that go together to make a rope. So we're making a rope here, essentially, and we make a large collagen fiber that's very strong, and it's cross-linked, and that's how we make collagen. So it's really almost like weaving together a rope like you would use for a ship or a boat or something. So the collagen fiber is the important part that will lay down the matrix that the calcium will come along and be deposited into bone, and that's the next step. So once the collagen fiber has formed the analog of the bone, you have ionized calcium come in that's circulating around in the system, and it'll start to be deposited in little holes within that collagen weave and start to stiffen it up to make a hard, solid bone. And during that time, the osteoblasts and osteoclasts are in there busily remodeling it and strengthening it and laying down layers of hard bone and making the marrow cavity that's softer, that isn't so important in support in a femur, but it is in the spine because it's those internal components, the trabeculi, that hold up the end plates, that when they get weak with osteoporosis, that's when you get your fractures. And that occurs in women generally after the age of 60 and men after the age of 70. Remember, a little caveat, 20% of people that have osteoporosis in the United States are in fact men. And that's most commonly due to low testosterone. Now, women, of course, is due to estrogen, and unfortunately, for many decades here, we haven't treated women postmenopausally with estrogen, which has now been come back into vogue to now be the treatment because it may turn out that it really didn't cause breast cancer. So two components, collagen and mineralization, are crucial to the growth, healing, and formation of the bone fusion mass. So bringing collagen together and depositing calcium into it, or one of the various calcium forms, will make the bone strong and make it able to support our skeleton. Now, fibrillin binds those collagen fibers together to make the matrix like a woven cloth that the collagen gets deposited in. And that's one of the defects. If you ever have any Marfan patient, you have abnormal fibrillin, so it doesn't bind together, it doesn't make good cloth, calcium can't get deposited well, and they get soft bone that's flexible, and particularly soft ligaments and tendons. That's why they're hyperflexible. Marfan's really, the defect is mainly in tendon, blood vessels, and joint capsules, which is why they're tall and lanky and hyperflexible. They get aortic aneurysms, their lenses dislocate, their kneecaps dislocate. They very commonly will also get flat feet. So keep that in mind when you're looking at a Marfan's, which is very common. It's like 1 in 20,000 incidents. And there's a lot of different kinds of Ehlers-Danlos which will have similar symptoms involving these various soft tissue organs due to the lack of good collagen to get good support in these various structures. So BMP is very important. After you cut off and trim the procollagen with the BMP1, it goes through a whole sequence where it stimulates the bone, specifically the osteoblast, to make osteocytes to make more bone. And it somewhat inhibits a little bit, perhaps, the osteoclast. So BMP is a powerful inducer, and we've really worked this out a lot. It's kind of fascinating, is that the BMP actually attaches to a specific receptor. It'll stimulate what we call SMAD proteins. These are on a lot of exams now because they are what regulate between the cell membrane and the nucleus. They're the messengers that go there. And it'll stimulate the DNA to produce RNA, okay, through various factors, and basically make more osteocytes that will make more bone. So this is why BMP can actually stimulate and heal fractures. And it's used widely for mandibles and for tibias, and also in the spine in more and more usages. Now, WNT is another factor that when you look at some of the other lectures, it's very crucial to the new medication called romosozumab, and it actually is blocked partially by that allows the osteocytes and osteoblasts to proliferate, to make more bone and get healing bone and help improve the osteoporotic condition. And that's how it works through WNT1. And it also stimulates blood vessels and circulation. And it also stimulates the beta-caterin. If you look at the other lectures, you'll see a better pathway to make the nucleus kick on, to make more osteoblasts, to make more osteocytes, to make more bone, and improve the overall condition of osteoporosis. If you ever wonder a thing called Wolff's Law, where stimulation of a bone, this is why we exercise. If we exercise, our bone is generally stronger, and it bends the bone. You remember, it's flexible, and it bends the endoplasmic reticulum where you make all these proteins. A lot of these structures have dual use, and when it gets bent, it actually stimulates the cell to make more osteoblasts and then osteocytes to make more bone. So that's why exercise, if you wonder why, builds bone and why you should recommend it, even if it's water aerobics, as part of the treatment plan for your patients with osteoporosis. It's all related to the physiology that we just talked about. So if you ever wonder why exercise helps, this is why it stimulates bone production. We'll talk a little bit about some of the basic science. All of this has been done in rats. It may actually be better to do it in pigs and things along this line because they're more similar to humans. But the basic science of parathyroid hormone, it stimulates both osteoblasts and osteoclasts. So it will actually make bone and also cause bone reabsorption. Now, if you wonder what abaloparatide and teriparatide are, they are parathyroid analogs. They are just part of that molecule that have a similar effect of stimulating bone production. And they are truly anabolic. Okay, they make you have more bone, which is why when you have somebody with really severe osteoporosis, these are the medications of choice. Now, I have written, along with some of my colleagues, bone health guidelines through the CNS, and also they've been published widely, that strongly recommend, if you're going to be doing some sort of surgery, particularly spinal surgery, that's why I have an interest in this, that you should put them on a parathyroid analog or an anabolic, which would include the romosozumab we just mentioned. I can't tell you the trade names, obviously, because it'd be a conflict of interest. But the bottom line is, we can talk about these. We're available to help you with them. But the bottom line is that PTH enhances the BMP signaling, okay, which BMP produces more bone, and it stimulates the cell cyclic AMP, which makes more cells, more activity, and that makes more cells in the milieu to heal the fracture, or in the case of a fusion, to get a fusion to take. And both PTH and BMP, they work together because I'll show you that their receptors on the cell are side by side. So if we have somebody on, let's say, teriparatide, okay, and a parathyroid analog or abaloparatide, it will stimulate the PTH receptor, and if they happen to have BMP used in a fracture or something, it will actually stimulate it to heal better. So they work synergistically. So PTH stimulates bone remodeling and induces differentiation of bone marrow. Mesenchymal stromal cells, MSCs, they're everywhere. There's what they want, make fibroblasts, chondrocytes, and actual bone, orchestrating activities of local factors such as bone morphogenic protein. So everything works together, and they're commonly used now. When I look at other areas that use a lot of these proteins for other things, of course I'm clueless too. So you can see that basically BMP comes in and stimulates a receptor. It goes across the membrane, it stimulates those intercellular SMAD receptors that basically cause the endoplasmic reticulum to produce factors that cause cellular differentiation. The MSC cells will differentiate into osteoblasts, osteocytes, and make more bone. Now, look at the top there, that little crescent with sclerostin. Sclerostin is the drug, is the factor that the romosozumab, the new product that's out, specifically inhibits. And what it does is, it actually, by doing an antibody, blocks it and allows proliferation of osteocytes to make more bone. So just you don't have to remember. Teriparatide, which is a parathyroid drug essentially, it mimics it. It's right beside it. It also stimulates the same cell to be even more active as far as producing bone cells to get bone healing. And ultimately, bone healing means stronger bone, less fragility fractures, and improvement of the osteoporotic condition. Now remember, osteoporosis starts as osteopenia. Half the fractures in the spine occur in people from 0.1 to minus 2.4 T-scores, because the bone's getting weaker that entire time. They just set this artificial metric of minus 2.5. But half the fractures in the spine, the compression fractures you see from just a minor fall, a floor level fall, they occur in people that have osteopenia before they can even, quote, have effective treatment. And so just keep that in mind. This is all going on kind of gradually over many decades and everything. So TGF-beta and BMP also work together. TGF-beta stimulates mesenchymal cells. They all work together. TGH-beta stimulates the SMAD pathway for increased metabolic activity within the nucleus to make more cells. And basically this results in all three of these things, TGF-beta, PTH, and BMP, they all work synergistically to stimulate the nucleus of mesenchymal stem cells that produce all of the other cell lines, and osteoprogenital cells that produce bone cells, osteocytes, to differentiate the osteoblasts to produce bone. So that's how that all works and everything. And when you look at the TGF-beta, it goes right to another receptor on the cell. If you have PTH floating around, they both stimulate the nucleus to produce more cells to divide, make more osteocytes, more osteoblasts that make more osteocytes. Lo and behold, all of a sudden, you start making more bone. If you make more bone, you get more remodeling, you get stronger bone. Putting these all together, you know that BMP stimulates the BMP receptor and the SMAD receptors to go ahead and make the nucleus proliferate and divide and make more osteocytes to make bone. You know WNT also stimulates vascular supply to the bone to make better healing and better bone, better remodeling, stronger bone, less fragility fractures. We also know that cell stress, remember the Wolff's Law, where if you bend your bone and exercise, it also produces more osteocytes via this intercellular pathway. If you use BMP and PTH together, in the case of PTH, we're going to be using one of the parathyroid analogs that we discussed, abaloparatide or teriparatide. And that combined particularly with a fusion or in a fracture, if you put some BMP in there, They really will stimulate you to produce even more cells quantitatively. And finally, TGF-beta will take primitive mesenchymal cells and make more of them, which these other factors can differentiate down into something that'll make us have stronger bone. Now, everybody can take a breath. We're over with all the heavy-duty lifting here and everything. So just keep in mind, we've worked out pretty well how a lot of these things work, at least that we can understand them. There are many nuances to how bone heals or tissue heals and how the skeleton functions that we may never know in our lifetimes. But this is to show you that TGF-beta and PTH will take a primitive mesenchymal cell that's everywhere in the lining of blood vessels, and it'll turn it into an osteoprogenitor cell. And then other things, TGF-beta and PTH, will take an osteoprogenitor cell to an osteoblast, which is a precursor to making an osteocyte, which is a cell within the bone that maintains and produces more bone to make it stronger, effectively more support to your skeleton, making you more resistant to a fall, and hope keep you from getting a fragility fracture, and ultimately it improves your bone health so you won't have osteoporosis, which I cannot tell you. This is one of the leading causes of death, is to get a fractured femur. And and a lot of people get the femur fixed with instrumentation, but if you don't treat the underlying osteoporosis, the same thing's true if we do a fusion, there's a pretty good chance you're going to break the other hip. And you know, that is a potentially fatal injury. And so this is why paying attention to the end game of all this physiology and improving the bone through some of these mechanisms we talked about, it's not important you understand them or memorize them perfectly, but you need to know we want to have the flow to make more bone, whichever pathway we choose. So we'll talk a little bit about history. Historical perspective of calcium and vitamin D metabolism. Severe bone deformity disease was first described in northern European cities in the 17th and 18th and 19th centuries. Well, with the urbanization of mankind, going from agrarian farmers where you're out in the sun all the time, you're making vitamin D all the time, there was never a problem with vitamin D deficiency. But as we became more urbanized and factory workers, and particularly with child labor, we started to notice that children that were in the northern latitudes that didn't get any sunlight started developing rickets. Well, we rarely see rickets in the United States now, but we see it when I've gone overseas. We certainly see it in other countries, but both from this reason and from lack of vitamin D in their diet or any number of reasons. But the whole point is that they noted that there was growth retardation, the legs classically bowed, spinal deformities developed, scoliosis, ribcage protrusions, or rossetic beating of the sternocostal joints, and they developed weak and hypotonic muscles. Autopsies of the 19th century showed that 80 to 90% of the people had rickets because they all lived inside. Outside, you didn't get a tan or anything. So a guy by the name of Sinadecki came along and first recognized that sunlight was important in 1822. The next person was Palm. He treated patients with actual sunlight and would put them outside for an hour so they would make enough vitamin D, and rickets was cured. Again, vitamin D is critical to the health of bone because sunlight makes it in the skin. You can make over just, a small area exposed for like a half hour will make enough every day. But if you stop and think about it, UV lights don't really provide you with enough UVB to make vitamin D. And if you don't make it, you're going to be deficient. And when we check people around the hospital with vitamin D levels, everybody was low. So I can tell you most of the people in my office take vitamin D regularly because we're inside so much, particularly in the winter. Holchinski came along and he used artificial light. Remember, electricity came along at the turn of the 19th century, and for 1 hour, 3 times a week, and he showed increased skeletal mineralization with biopsies. Milhani prevented rickets by giving supplemental oral cod liver oil, and that would give them enough vitamin D because it's very high in vitamin D. I actually tried vitamin D once, and it's the worst thing you can possibly, cod liver oil and vitamin D, and it's the worst thing you can ever taste. But they did start to supplement urban children in particular with this, and it was named finally vitamin D by McCollum in 1922. And by the end of the 20s, vitamin D2 in yeast was added to milk, 400 international units, or 25 nanograms per quart in 1929. And that continues to this day. We add 400 units of vitamin D. We tend to really want to do vitamin D3 as our final metabolite. So that's kind of the history of vitamin D. We know as orthopedists that the disruption of any sort of major organ system will result in bad bones. And you know this, when you get kidney disease, you can just see how people end up on dialysis, and they all have terrible bones, and they get fractures and all sorts of other problems. So when you look at vitamin D, sunlight, UVB, okay, it penetrates the skin, and the precursor to vitamin D, 1-dehydroxycholecalciferol, is in the fat. And that's converted basically in the fat to vitamin pre-D3, which is really D2. So the next step is that's bound to proteins in the body, okay, and it's taken to the liver. Now, likewise, you can be taking D2 in cod liver oil orally through your GI tract. Well, let's say you have celiac disease and you have poor intestinal reabsorption of vitamin D. Guess what? It's one of the causes of osteoporosis. And we just saw a gentleman the other day, because we screened for this, we'll go over the testing, and every single one of his testings on celiac disease was way out of whack. So that's why he's got osteoporosis. His T-scores are like -3.0 as a male, and his testosterone is normal. And so that's his cause. So any GI problems, such as celiac disease in particular, Crohn's disease, ulcerative colitis, all those things can affect your vitamin D metabolism. And of course, liver disease, because out of the circulation it'll go to the liver, and it'll basically be hydroxylated to 125 with hydroxylase vitamin D, which is vitamin D2. Think of all the people that have bad liver disease, various kinds of hepatitis or alcoholism, which is why most alcoholics have bad bone. They have both osteomalacia because they make poor collagen, and they also have osteoporosis too. So just the liver is very critical, and there's a lot of liver disease, and if they've been taking Dilantin, which blocks the production of D2, please check them for osteoporosis. Even if they're 30 years old, they may have bad bone. And if that continues through a lifetime of anticonvulsant use, they're going to be in big trouble. So out of there, this next goes back to the circulation, and goes to the kidney. Well, this adds another OH to it, makes it 125 hydroxylate, and that's active D3. That's the vitamin that causes bone production and facilitates the calcification of the bone and the hardening of the bone and the whole process. And so kidney disease is critical. It will definitely cause poor bone health. It interferes with the metabolism of the bone, and people with kidney disease, if they have it, you should check them out for potential osteoporosis. So the 125 goes back into the circulation, and it will actually shut down absorption a little bit in the gut, but what it mainly does is facilitate calcium reabsorption, and of course it also goes to the bone to facilitate bone healing, bone production, and bone physiology. Now, if it gets too much 125, this is one of our classic board questions, is it'll actually shut it down. Now, parathyroid hormone comes in here, and it will cause the kidney to uptake calcium more, and it will be kicked on if you've got low calcium, right? Or if you can't reabsorb it from a sick kidney, it will automatically start to take it out of the bone, which is why it's one of the biggest causes of parathyroid adenoma, for example, of developing poor bone. And so PTH is very powerful, but we have analogs, teriparatide and abaloparatide, that don't have that effect. All they do is stimulate osteoblasts into osteocytes to make more bone. They don't mobilize all the calcium out of the bone, and that's because they're half of the molecule. Does that make sense? So there are other things. There's the feedback loop that 24-25 shuts it down, and of course it affects all of your skeletal support system, your neurological system, your metabolism, and your muscular system. They're all critically related to the fine balance of calcium circulating controlled by PTH, and it's controlled within a very narrow level. We'll talk about that in a minute. Bone health begins with normal calcium and vitamin D metabolism. Vitamin D, phosphorus, PTH, calcitonin, we've talked about that. Abnormalities in vitamin D3 causes rickets. Hypophosphatemic rickets, if you're losing phosphate, it lowers your calcium because they're in a close ratio. And unfortunately, that's vitamin D resistant rickets. And of course, you have osteoporosis and osteomalacia. Like this lady to the right, she has a T-score of about -5. And she's had all these fractures through her spine. And it turned out she had a parathyroid adenoma that had been missed. And she basically leached her skeleton of all the calcium. It will just keep going and dumping all the calcium through the kidney and mobilizing out of the bone until you basically have a much higher ratio of the collagen compared to the bone matrix, stiffening it up. Now, I want you to remember these. These are the general testing that we do when we get somebody with really severe osteoporosis. These are our suggested things. And the little starred things are the things I want you to pay particular attention to. Vitamin D3 level is you should take on all your patients, I think, on a regular basis because it's frequently low and it needs to be supplemented. If it's fine, you don't need to do anything. Taking more vitamin D won't help. Serum calcium, phosphate, magnesium, these are very tightly controlled, and when they're out of whack, it means you've got some sort of major metabolic problem, usually with the kidney. Albumin, if you have low albumin, you don't carry calcium as well. It'll make it look artificially low. Parathyroid hormone should be checked, and also TSH, because hyperthyroidism will actually cause osteoporosis, and hyperparathyroidism will cause osteoporosis. So you need to check your PTH levels. Low vitamin D will bump those up too, by the way. Serum alkaline phosphatase, if you have a high level, then you may have a cancer somewhere, particularly myeloma, we'll talk about. Testosterone in males should always be checked. It's frequently low. Renal function should be checked, particularly the GFR. A serum protein electrophoresis, I cannot tell you how many cases of benign MUGUS or frank myeloma or plasmacytomas we picked up over the last 2 years by doing this regime, at least 6 or 7. And so you'll pick up a lot of ancillary other diseases that up to the point you do the testing are quiescent, you can't tell, and you may really help somebody long term as far as their survival rates. So we always recommend a serum protein electrophoresis, particularly if they've had a compression fracture from a minor fall. You should check this, and we just had a lady this week that turns out to have myeloma. The celiac screening panel is worthwhile doing along with the 24-urine cortisol to see if they have if they have some sort of adrenal problem where they have a lot of endogenous steroid floating around. This is a myeloma. This is one of the patients we picked up, and you can see that has a kappa band, and it's an IgA myeloma. We picked this up on screening, and the male came in. He was having back pain. We didn't really see too much, and then we started taking some x-rays, and he's got some sort of lesion in L2. You can see there on the right on the PA view, and we're really concerned. So we get an MRI, and he's got all these little lesions all the way up his spine, multiple lesions, with an emphasis on multiple. So we go ahead and we get the CAT scans. You can see it's a classic destructive collapsing vertebrae. Until it broke the top end plate, the patient probably didn't have any pain. But once they get the pathological fracture, that's when they're going to present to your office and then subsequent to us for treatment. And this is a bad fracture because 95% of the vertebrae is gone, and it's already broken, and he's kyphotic, and he's got bone and extension into the cord. We will often just treat these with chemotherapy and send them right to our oncologist, and they're remarkable with what they can do. But once you have structural destruction, it doesn't reverse very well. And here's the MRI. You can see it's pushing. When you see the wall of the vertebrae push back into the canal, it's plastically deforming. That's almost always a tumor. When it's a compression fracture, that wall will be preserved, and it'll be just the front part of the vertebrae that's wedged where the end plates are smashed. It's a quick way to tell if you get your MRI. So when it starts to bulge backwards, it's almost always a tumor, just a little caveat. And you can see on the cut, you can see it's actually cracked and fragmented and starting to go into the canal. It lights up on the bone scan. So we took this patient with our Norton, after the bone team identifies these kind of problems. We have this is why we're there, and we took out the fractured vertebrae, put a strut in there, and did it. And then we biopsy at the same time. We killed 2 birds with 1 stone. You can see there's plasma cells everywhere, and a immunoglobulin stain clearly shows that it's a plasmacytoma with multiple myeloma extension. So calcium metabolism, it's absolutely essential for normal muscle contraction, nerve conduction, hormonal regulation, renal calcium excretion. It regulates that very finely. It's maintained within a very narrow range. And it does that by regulating plasma membrane intercellular organelles, okay? And it's an intercellular second messenger. It actually goes through the cell membrane and actually stimulate activity within the nucleus itself. So the total body calcium is about 1.0 to 1.3 kilograms. Remember, most of that's in the bone. 95% of it's in the bone. So when you look at the distribution, 1% in body fluids, 99% in the bone. Most of it's intracellular, extracellular, a little bit there, but it's usually about 375 milligrams per 10 milligram or 10 milligrams per deciliter, 375 milligrams total of circulating. And half of it's ionized. If you're having trouble with low albumin, you can always get an ionized calcium, which will tell you the normal range of that. And so that's the quick way to do it. Normal ionized calcium is lower by around 5 average versus 10 average, and most labs will measure in those general ballparks and everything. And usually if it's low and they have low albumin, that's why it does. So remember to know how it circulates in the circulation. Alterations of calcium metabolism. If you have low calcium, you have hypoparathyroidism, pseudohypoparathyroidism, vitamin D deficiency will cause it, and of course renal disease. Elevated calcium, hyperparathyroid is one of the most common things. We probably find 5 or 6 adenomas a year, sometimes not quite that, and cancer. If it's elevated way up, think cancer, particularly the hematogenous cancers like myeloma, or anything that's osteolytic that dissolves the bone. And those can include breast cancer. Prostate's usually more osteosclerotic. Remember sarcoid. Granulomatous diseases elevate calcium because they produce vitamin D that stimulates cells to mobilize and basically dissolve the bone. Along with these other things, hypercalcemia, if you've ever seen that, the patients will come in and you check their reflexes and they'll go right into clonus. They'll have seizures, they'll have laryngeal spasms, sometimes they'll develop hypotonia in the muscles, and they have trouble breathing. A lot of bad things happen. So when you have hypercalcemia, it's something that needs to be addressed immediately. It's a medical emergency, and you should be taken care of very quickly. Hypocalcemia generally just causes some neurological symptoms such as tetany. We'll talk about the effect of obesity on bone metabolism, what orthopedic surgeons should know and you should know. Some people think that because you're morbidly obese, it shields you from osteoporosis, and that's somewhat generally true because as you carry more weight, remember Wolff's Law, the stress to the endoplast reticulum, it makes the bone stronger. But that's not always the case because a lot of these people are now have in the past gotten bypass surgery, which dramatically will change your calcium levels and vitamin D levels and interfere with calcium absorption and vitamin D absorption. And that results in the development of PTH elevation and mobilization, and they may actually get softer bones. And of course, now we're in the age of GP1 blockers, right? And there are several papers, I can tell you, coming out in orthopedics, and I'm sure in the medical literature, that those do decrease muscle mass and also decrease bone mass. Well, they cause universal loss of fat, bone, and muscle. So they all equally get hit. And you can counter that by exercising more rigorously, exercising regularly, and not just sit around and lose weight, but take advantage of that weight reduction and do some exercise to increase your muscle mass. And there are programs and things that will actually, I believe, because we put them on, I hope they're doing the job, will make people stronger. And so that's something to be aware of as far as osteoporosis. The other thing you have to worry about if you give them too much calcium, there are a few papers that suggest it may cause an increased cardiovascular risk, but you've got to be taking, like milk alkali syndrome, where you're taking a bottle of Tums a day. So several studies have shown there's no effect. Some studies have shown that it does affect. I think that you should, if you have a calcium issue, you probably should give some, but not a lot. So that's still debatable. As far as taking vitamin D itself, the VITAL study said if you have normal vitamin D levels and you're normally active, okay, and it was a prospective randomized study, vitamin D did not reduce the risk of fractures. So taking more vitamin D is not going to make your bone stronger. It's going to keep it from getting weaker. Our goal is to keep your bone as strong as you are, because remember the T-score compares you to a 30-year-old person, and we want to keep that gap between when you're 75 as small as possible. So if you can get into your 70s with a minus 1.5 T-score, you're probably doing pretty good. And that takes exercise, attention to vitamin D. So they found that taking a whole bunch of vitamin D does not decrease your risk of that. It's all the other factors. Remember, everything's a combined treatment on this. Now, vitamin D is essential or critical and extensive. It stimulates the pancreas to produce insulin. Remember the hormonal effect. It decreases renal production of renin. Okay, it'll actually cause, it's important within the cell itself. It's intracellular in maintaining normal cell proliferation and differentiation. If you don't have it, your tissues go to pot universally. It also can be produced by the colon, prostate, and breast in small amounts. And it also it regulates within the cell the growth and maturation. It's a hormone both intracellularly and also extracellularly. And they talk about that. It can be autocrine, which simply means it affects the same cell itself, self-regulating. That's why it has to be in the cell. You have to have proper levels of it. Panacrine, where it regulates the cells beside it. And of course, it can also regulate cells systemically all around the body. These direct effects decrease the accuracy of measuring circulating vitamin D. So you may have pretty good vitamin D contained within all the cells, but it may not necessarily be a circulating vitamin D. The bottom line is you should have a greater than 30 nanograms per milliliter, okay? And that should probably be year-round. Interesting caveats. You find vitamin D in the fetal trophoblast, maternal decidual cells, early in gestation. It appears to have an immunosuppressive effect on vitamin 125D3, and this allows the placental trophoblast invasion of the wall without triggering an immune response. It's tied in with immunity, by the way. You get monocytes and macrophages express the vitamin D analogs. There's clinical evidence that macrophages are associated with sarcoidosis and granulomatous disease have increased production of vitamin D3. Makes sense, right? It causes bone turnover. It can cause elevated, all sorts of problems with elevated vitamin D. But the bottom line is these are just to show you that it has widespread tissue effects through virtually every tissue in your body. So monocytes cause sarcoidosis. I can never understand why sarcoidosis causes increased calcium, and now I know. So if you get a patient with this, it's really pretty rare. And we've had one or two that have had spinal involvement. I grab those cases. So when you have a calcium deficient diet, you have inadequate calcium, you have decreased plasma ionized calcium, it increases your PTH, it causes vitamin D to be produced to try to increase absorption. It increases PTH and kidney, it'll basically reduces the excretion. It increases renal phosphorus excretion, which will cause hypophosphatemia. But the bottom line is if you can't keep up with it, you eventually keep losing mineralization, and that is one pathway that the calcium causes. Very rare to have calcium deficiency from diet. Now, vitamin D, much more common because you're not in the sun, as we talked about. So you don't produce as much vitamin D3 through the liver, through the kidney. Disease in any of those will lower it, and that reduces the gut absorption. It reduces the plasma ionized calcium gets affected. You get increased PTH excretion. The kidney dumps phosphorus, excretes calcium. You get bad bones. You get rickets, and you can potentially get a metabolic osteoporosis going on. So they both work and end up at the same place, but to a little bit slightly different mechanism. It's just think about what it does with rickets. Really, the COLA1 gene, you end up, in this case, having poor collagen, and you don't take advantage, if you're vitamin D, of ossifying your bone as much as you could. But these are just some of the foods that you can, if you're interested. I personally like shiitake mushrooms. They have a lot of vitamin D3 in them. Cod liver oil, if you can stomach it. Fresh salmon, if you like salmon, it's loaded with vitamin D3. But these are all things you can do. I mean, most people, take a multivitamin and pop a D3 in the morning because it's just simpler. You don't have to go fishing and dress a salmon or something. On the right, I want to show you how worldwide and how severe vitamin D deficiency is. And we'll talk more about this in the other two lectures we've already recorded. But the bottom line is, look at Caucasian females, 9 to 11, are less than 20 milligrams. These are kids that are growing, that are ossifying their skeleton. It'll never be as good as it can. Remember, you can add bone mineralization to your skeleton till you're about 28 years old. And after that point, you lose calcium, you lose bone density for the rest of your life. Now, you can go like this, or you can just slow it like we talked about and lasting till you're 70 or 75. But the bottom line is, if you smoke, or you don't have enough vitamin D, okay, or if you, for example, don't exercise at all, these are all things that make that loss much quicker. And going back to the physiology, we can biopsy your bone marrow, and we can see there's a net reduction in the osteoprogenitor to osteoblasts to osteocytes that make the bone, that prevent fractures. We can see there's a net increase and diminution of those as you get older and older and older. So from age 30 on, that's why you get osteoporosis, because your cellular ability to produce bone goes away or decreases exponentially, particularly when you get into your 7th and 8th decades. Look at Hispanic children, less than 20. Children worldwide are chronically vitamin D deficient. That's why you give your children a good diet, make them exercise, and give them some sort of vitamin supplement if they're not out in the sun. When you're a mother, pregnant, that's why we give everybody vitamin D, I would hope, because it almost always becomes deficient. So one of the interesting things about vitamin D is it also affects the immune response. If you remember back three or 4 years ago now, everybody was saying you should take vitamin D for your COVID. Well, that we don't know if that really was effective, but what we do know is that vitamin D is important for macrophages to become activated, and when they become activated, they will phagocytize particularly bacteria, such as tuberculosis, and they will become cidal for it. And so that's one of the way they work, is they go through and they basically will take the bacteria and phagocytize it, and having D absorbed into the cell dramatically increases the cidal nature of the macrophages, and it causes B defense into cathelicidin, which causes microbial killing. It enhances the production of that within the macrophage. So it does have some sort of immune effect. It probably is more related to bacteria and less to viruses. So the vital study. Some people think that vitamin D we're circulating can really negate the risk of cancer. And so the VITAL study, which also said you don't need to take vitamin D excessively, came out and said that it may reduce the incidence of advanced metastatic or fatal cancer in the overall cohort of adults without a baseline diagnosis of cancer. I think what it really said, because they went back and they reanalyzed it, and they found that when you look at the bottom here, there's not a lot of difference between both groups, the ones that had placebo or vitamin D, and then confirmed metastatic cancer or cancer deaths of any type. But what it really probably was stratifying out in the 12,000 per group numbers were that the people that were probably healthier and took vitamin D, and they were more likely, I think, to pay attention to their health, and they probably, we all know that if you're less obese, exercise more, eat a good diet, that your cancer risk are probably decreased. And I think it might have been just kind of catching some of that effect, because when they really did a sub-analysis, there wasn't any definitive proof in that study that it reduced your cancer rate, which is important to understand there, as you can see there. So we're coming to the end here, but I think it's important to understand the physiology, to understand why we treat it. And I ask you to look at the next lecture, because you're going to see why all of this is important, because we have to understand this before we can effectively treat, diagnose it in particular, and what our x-rays are showing us, and why it looks osteoporotic, and why the ROIs, the region of interest on the CAT scan, are lower because of the loss of mineralization of the bone itself results in lower x-ray readings with the region of interest on that particular testing modality. And the same thing is true with your DEXA scores. The beam goes through easier the softer your bone is. So the less calcium, the more it goes through, the lower the reading. Remember, osteophytes interfere with that. So by giving you some of the basics of the physiology, my hope is that you'll be able to take this, a few kernels of it, and some of the caveats I've told you, and apply that to the next couple lectures to give you a better idea of why you're treating it and how you're treating it and what it's doing to the person themselves too. So in summary, bone quality and quantity issues can exist at any ages. We looked at children between the ages of 9 and 11, and we saw that they went for 225 Hounsfield units, which is a T-score of 0. They went all the way down to about 150, which is a T-score of minus 1.5, and then they come back when they're teenagers back to 225. So during that growth spurt, we wonder whether or not that softer bone in kids that have scoliosis, it may make the bone softer and cause it to progress. That's why we're doing the study. So it can occur at any age, and I've seen many a child with dietary poor vitamin D intake that will show in later case presentations where they get in a simple wreck and they have like 3 or 4 fractures, burst fractures, when they're 16 years old. Well, they shouldn't have that, but when we checked their vitamin D level, it was like 10. And so keep in mind it occurred at any age. Think outside the box. Remember, your eyes see only what your mind knows. And the more you got packed in there, you can say, oh, you know, they mentioned that it can occur at any age, so keep that. You have to understand the metabolism. I think you probably got a hopefully have a good handle on that. Remember that vitamin D and calcium are tightly regulated, and you need to keep them in normal levels. The most common cause of risk worldwide is still dietary. We get good sunlight now, and we know what to do, but a lot of kids still, for example, they have the Dorito diet. Particularly, you'll see that in some autistic children or other children, where they'll just eat Doritos and Coke, and those are terrible things for this. And so you got to remember that corn has no B2 in it. You know, that's why you get pellagra. And so all these things are things you should kind of keep in your noggin there. There's extrarenal production. Remember, it is a systemic hormone. Also, not just regulates bone health, it regulates cell metabolism. Osteoporosis and Malaysia, our metabolic disease must be treated to prevent potentially catastrophic fractures. If you get a spine fracture from osteoporosis, from a fall from height, a fragility fracture we call them, you should do what we call a frac scoring. And by definition, if they have a vertebral fracture or a hip fracture just from falling from height, that by definition means they have osteoporosis. And you can proceed to treatment without a lot of gobbledygook and other testing if you want to, if you don't have it available. But try to identify it and treat it, because if you break one, you're going to have a 50% chance of breaking one within 6 months, and if you have 2, you're going to absolutely break another one very quickly, because you get more and more kyphotic, more stress on them. So keep that in mind. Finally, bone metabolism significantly affects all our treatment as orthopedists, whether you're fixing a femur, a forearm fracture, or a spine fracture, or doing just routine elective surgery. Keep in mind that if you see a distal radius fracture and you happen to get a DEXA score that's low and the spine and the hip are still normal, there is a pretty good chance that within 10 years that patient's going to develop osteoporosis. That's a hallmark and a harbinger of developing osteoporosis when you get a distal radius fracture and then you find on DEXA scan, you'll find that it's low, but you may still have normal hips and spine. So keep that in mind. That's some of the new literature is coming out, is that's one of the harbingers of having basically a future fracture. So that ends our lecture. If you have any questions about this, you're more than welcome to call myself or any of the other people I mentioned if they're in your area, like Dr. Curry's out at Women and Children's and Dr. Teeter's over at Clark County. And of course, we're downtown and we have nurses. We all have nurse practitioners that can help treat and help you with osteoporosis. Thank you.